Hi guys, we were discussing respiratory tract infections. Among URTs, we accomplished otitis media. Today, let us look into the salient features of pharyngitis. Let us begin with the definition. Pharyngitis is an acute infection of oropharynx or nasopharynx. So, the name itself indicates or suggests the definition. So, itis means inflammation. So pharyngitis is nothing but the inflammation of the pharynx, especially in the oropharynx or nasopharynx. So in this figure, you can see the inflamed oropharynx or nasopharynx. So this occurs in 1 to 2 percentage of all outpatient visits. Now let us see the etiology for the pharyngitis. So which all microorganisms are responsible for the development of pharyngitis? So viruses cause most of the cases of acute pharyngitis. So most common cause is virus. So this can be rhinovirus, coronavirus, adenovirus, influenza virus, parainfluenza virus, and Epstein-Barr virus. So among these, rhinovirus, coronavirus, and adenovirus are the most common than the others. So when this occurs, what is the time for this type of infections? So the viral infections are more common during the winter season, except for adenovirus, which occur year round. Although viral causes are most common, bacteria can also cause pharyngitis. So, do you know which is the primary bacterial cause for pharyngitis? It is nothing but GABHS, that is group A beta hemolytic streptococcus. So, they are also known as GAS or Streptococcus pyogenes. So, the synonyms of GABHs are GIS or Streptococcus pyogenes. So, they are nothing but the bacilli, Streptococcus gram-positive bacilli. So, these can be the primary bacterial cause for pharyngitis. The bacterial etiology for acute pharyngitis is far less likely. Of all bacterial causes, JBHS is the most common. Other less common causes of acute pharyngitis include group C and G streptococcus, corynebacterium diphtheriae, Neisseria gonorrhea, Mycoplasma pneumonia, Arcanobacterium hemolyticum, Chlamydia pneumonia. So these are the less common causes of acute pharyngitis. Now let us see the pathophysiology of pharyngitis. So how these etiologic agents leads to the pharyngitis. So normally the pathogenesis of pharyngitis is not well understood, but many theories have been offered. So pharyngitis is frequently found in the setting of a viral upper respiratory infection. So usually it follows viral infections. So let us see how these infectious agents leads to pharyngitis, or what are the salient features in the during the infection. Okay, so when we are getting infected with rhinovirus, what happens? They can produce inflammatory mediators such as bradykinin and lysyl bradykinin. So these inflammatory mediators can excite the nerve endings in the pharynx. Okay, so our pharynx is lined with the nerve endings as well as the nerve supply as well as the blood vessels, right? So when these inflammatory mediators are released as a response to this virus, what happens? they can excite the nerve endings in the pharynx, and this results in the pain. So this is the reason for the throat pain. So many research were conducted. So research done with the laboratory animals found that viral infections produced an inflammatory response by invading the pharyngeal cells. So how they can cause the inflammatory process? These viral agents or the bacterial agents, the viral agents can enter the pharyngeal cells and they can invade it. So this they promote the inflammatory response. All right. So this adenovirus and the Epstein-Barr virus, what are their silent features? They can produce lymphoid hyperplasia as well as tonsillar exudates. So, when we are getting infected with adenovirus and Epstein-Barr virus, we can see the patient may have lymphoid hyperplasia as well as tonsillar exudates. Whereas the infection with Streptococcus B, what it do? It produces inflammation of the posterior pharynx. So you can see the inflammation in the back side of the pharynx when there is infection with Streptococcus group B bacteria. So in patients with Epstein-Barr virus viral infection, as many as 10% of patients will have a GIS superinfection. So, those who are getting infected with Epstein-Barr virus, you can also see the chance of superinfection with GABHS or GAS. In some patients, infection with Corynebacterian diphtheria pharyngitis, infection with Corynebacterian diphtheria, you can see the posterior pharynx membrane becomes in gray in color. That is, you can see a gray membrane over the posterior pharynx. So, in case of GABHS or GAS or Streptococcus pyogenes, which is the primary bacterial cause, how they are transmitted into our body? They can be transmitted through inhalation or contact with the secretions. So, several studies have been conducted with this infection with the GABHS. So those studies shown that if a person is colonized with Streptococcus pyogenes, then 10% of the family members will become colonized. Okay, so they can be the carriers. So if that person becomes symptomatic pharyngitis, then the family members will become colonized increases to 25%. Okay, so the risk increases if the patient becomes symptomatic. So research has shown that school aged children are most likely the initial carriers of streptococcus into the family unit. So mostly this pharyngitis occurs in the children than adults. Alright, so what happens? The children can be the primary source or the primary carriers to the family units. So in patients who are colonized with 40% will develop streptococcal pharyngitis. Okay, so when the carrier amount becomes 40%, the patient can be infected with streptococcal pharyngitis. So differentiating streptococcal pharyngitis from other causes is an important step because GIS is the only major organisms to which we are providing antibiotic. Okay, so only to GAS we are mainly directing the antibiotic therapy. Okay, so GABHS infection has also associated infections regarded as complications. These complications include acute rheumatic fever, toxic shock syndrome, and acute glomerulonephritis. So when we are treating pharyngitis with positive findings of GABHS, then we have to take care of fact that the patient is having these complications or not. Let us look into the clinical presentation and diagnosis that a patient come across. So, generally, a patient may have sore throat that is self-limited mostly, and it will be sudden. Uh, you can say sudden onset of sore throat. Also, you can see fever and constitutional symptoms. Mostly, it results in about 3 to 5 days. Clinical signs and symptoms are almost similar for viral causes as well as the non-streptococcal bacterial causes. So, let us see the signs and symptoms in detail. Sore throat, mostly you can see sore throat in almost all the patient, and as well as while swallowing the patient may experience pain. You can also see fever in the patient, especially in the children. You can see signs and symptoms such as headache, nausea, vomiting, and abdominal pain. Erythema or inflammation of the tonsils and pharynx with or without patchy exudates can be seen, although enlarged tender lymph nodes also can be found, as well as red swollen uvula, petechiae on the soft palate, and a scarletiniform rash can be found. Several symptoms that are not suggestive of group A streptococcus are cough, conjunctivitis, coryza, and diarrhea. So, the signs and symptoms which are not suggestive of group A streptococcus can also be found. So, it's important to distinguish the streptococcal pharyngitis from other causes. Now coming to the laboratory tests. So throat swab and culture or rapid antigen detection testing are the main laboratory tests. The gold standard for the diagnosis of GS is the throat culture. Okay. So the diagnosis of acute GS pharyngitis should be based on clinical grounds and then verified by rat or throat culture. So rat is nothing but rapid antigen detection testing. Okay. So there is a great debate as to what clinical guidelines should be implemented. So mostly we recommend using the center criteria. So we recommend using the center criteria as well as including the seasonal risk factors such as November to May months, then personal or family contact with the history of rheumatic fever. So center criteria means fever, tonsillar exudates, absence of cough, then cervical lymphadenopathy. If you are seeing these signs and symptoms, they are included in the center criteria. So if a patient has one or less of this criteria, okay, then what happens? The GS is less likely, so no further testing or treatment is needed. So for two or more, so for two or more criteria, we recommend either rapid antigen test or throat culture. So, the Infectious Disease Society of America, they recommend that if a child has a negative RAT, that is rapid antigen testing, then it must be confirmed by a throat culture. If either the RAT or the throat culture are positive, then the treatment must be started. So we have to make sure that the child is free of GABHS or GIS. So we can confirm it with the help of RIT or the throat culture. So throat swabs can be used to diagnose pharyngitis as well as other infections, epiglottitis, Vincent's angina and diphtheria. So in this figure you can see the collection of throat swab. So throat swab specimens are collected by depressing the tongue with the help of a tongue depressor or a tongue blade, then introducing the swab. You can see the swab here. So introducing the swab between the tonsillar pillars. So here is the tonsils. So inserting the or introducing the swab between the tonsillar pillars behind the uvula. So you can see the uvula here, behind the uvula, without touching the lateral walls of the buccal cavity. So swab is introducing into the pharynx without touching the buccal cavity. Okay, and swabbing back and forth across the posterior pharynx. So we are collecting the specimens from the posterior part of the pharynx. So the swab specimens which are collected for the detection of the etiologic agent, how they should be placed. So for the detection of virus, what we have to do, we have to place them in a viral transport media, whereas for bacteria we have to place them in a tube transport system containing modified Stewart medium. Okay, so swab specimens collected for the detection of viruses should be placed in a viral transport medium, and those for the detection of bacteria should be placed in a tube transport system containing modified Stewart's medium. So other rapid direct tests for GS are less sensitive. Mostly they are sensitive, but they are less sensitive than the throat culture. So if we are performing any of those rapid antigen detection testing, we have to collect two samples. So we have to collect two throat swabs. So why we have to do that? If the direct test is positive for if the direct test is positive, what we have to do? The second swab should be discarded. Whereas if the direct test is negative, a confirmatory culture must be performed using the second swab. So, in adults, because the incidence of streptococcal infection and the risk for the rheumatic fever are low, the diagnosis of group A streptococcal pharyngitis on the basis of a rapid direct test without confirming a negative result with culture is an acceptable alternative. So remember, that is in the case of adults. So the gold standard for the diagnosis of GIS is the throat culture. So here you can see more clear picture. So you can see the tonsils, then you can see the posterior side of the pharynx from where this swab is collected. Now coming to the treatment, let us see how we can manage pharyngitis. Coming to the goals, what should be the aim, how we how we will manage it. So we should have aims to manage the pharyngitis, right? So we have to improve the clinical signs and symptoms, minimize the adverse drug reactions, and the most important one is to prevent the transmission from one person to another, and then prevent the acute rheumatic fever and separative complications such as peritonsillar abscess, cervical lymphadenitis, and mastoiditis. Coming to the pharmacological therapy, so the treatment with the antibiotics should be limited, especially those who are not having GAVS infection. So, for the relief of pain, we can use analgesics such as acetaminophen and NSAIDs. And the first choice of treatment is penicillin and amoxicillin. So, let us see the antibiotics and doses for group A beta hemolytic streptococcal pharyngitis, that is GABHS or GAS infection management. So here is the chart. You can see the preferred antibiotics for the pharyngitis. So we can use penicillin V in children with a dose of 250 milligram twice daily or 3 times daily orally for 10 days, whereas in adults we can use with a dose of 250 milligram 4 times daily or 500 milligram twice daily orally. Whereas penicillin G benzathine can be used only one dose. So this should be based on the body weight of the patient. So if the patient is having less than 27 kg, we should give a dose of 0.6 million unit, whereas those who are having body weight of 27 kg or greater, we can provide 1.2 million units through intramuscular route. And amoxicillin we can given for 10 days with a dose of 50 milligram per kg once daily. So maximum dose should be 1000 milligram, whereas 25 milligram per kg twice daily. So the maximum dose should be 500 milligram. In case of penicillin allergy, we can provide treatment with cefalexin, cefadroxil, clindamycin, azithromycin, as well as clarithromycin. So our antimicrobial treatment should be limited to those who have clinical and epidemiological features of GABHS pharyngitis, that is with positive laboratory test. So mostly the duration of therapy for GABHS pharyngitis is 10 days. So here you can see almost for all drugs its duration is 10 days except for benzathine penicillin and azithromycin. So these 10 days of duration is to maximize the bacterial eradication. And most cases of the pharyngitis are self-limited. So earlier we discussed that most of the URTIs are self-limited, right? However, antimicrobial therapy will hasten resolution when given early to proven cases of GBHS. So as early as we are treating the patient with antibiotics, it's easy for the recovery. So, symptoms generally resolve by 3 or 4 days even without the therapy. So, follow up testing is generally not necessary for index cases or in asymptomatic contacts of the index patients. So, when we are providing penicillin or amoxicillin or the and antibiotics such as cefalexin, clindamycin, azithromycin or clarithromycin, what they are what they are doing, they are destructing the bacteria, either bactericidal or bacteriostatic. So mostly penicillin or amoxicillin interferes with the peptidoglycan cell wall synthesis, and thereby they inhibit the bacterial proliferation. So they are normally bactericidal in nature. So mostly penicillin and amoxicillin are used as the first choice of drug for the treatment for pharyngitis. Thank you.